This is Krista. Welcome back to Made to Be Whole. Stay tuned for this week's episode on a cancer case study and some insights for healing from the dreaded C. Made to Be Whole is intended for informational purposes only. It's not intended to replace the advice or care of a licensed healthcare professional. Participating in this podcast does not constitute a provider-patient relationship with Krista Michener, AHP Integrative Health, or any of the guests featured on Made to Be Whole. Krista Michener, AHP Integrative Health, and any featured guests aren't responsible for any losses, damages, or liabilities that may arise from use of information obtained in this podcast or associated materials. Please consult a healthcare professional for any health-related concerns that you are experiencing. Welcome back. Today we are going to be sharing with permission a cancer story. This is actually my mom's story. So I think there are a couple of instructive things. She was diagnosed in 2020 with breast cancer, and she had actually had a normal mammogram within the year, but she felt something. It wasn't a lump, it was more like a ridge. And so she pushed to get it checked out. A couple of things in that initial process, because I'm going to focus more on the later end of the journey. I remember being there with her at the oncologist's office, and she had opted for a double mastectomy, and they pushed her, this one nurse, to just have a unilateral mastectomy. And she kept saying, some women are just happier if they have one natural breast, yada, 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 body image. And first of all, I'm thinking, I can't think of anything less natural than just having one breast. I'm kind of for symmetry, but my mom was just adamant. She knew what she wanted and didn't let herself get pushed around. She said, listen, I'm 70, whatever years old she was at the time. I don't care about my breasts. I want to be here for my grandchildren. So she went ahead and had the double mastectomy. And interestingly enough, when they did it, they found that the cancer was in both breasts. It had only been detected where that primary lesion was, but she had dense breasts. And because she was willing to kind of stick to her guns about what she wanted, she was spared having to go through the whole thing all over again. So she did chemotherapy, some radiation, actually tolerated it really well. The worst thing about that initial treatment was that your immune system's suppressed and you're isolated and COVID's happening all around you, which is just further isolating. And I remember being frustrated because there wasn't even the NCAA tournament to watch. The world had been canceled and you're stuck at home. But she persevered. She did really well, was very diligent about her oncology follow-ups. I didn't really nose into what was happening at those because she had had a good experience with treatment. She was following up. She was fine. She had gone earlier this year for a follow-up and had mentioned to them that she had some rib pain, and they said it wasn't a big deal and wouldn't be cancer related, and that she was doing so great she could wait and come back in a year. Well, a couple of things happened around that time. First of all, she had had some liver imaging that was abnormal. It turned out to be fibrosis. She had gone to see a liver specialist, did not have a good experience with that, but was kind of on edge around that. Then she developed this severe cellulitis on the right side of her body, which is the side that the primary tumor had been and where there was some lymph node removal. And it was pretty dramatic, sudden, severe. I was going to her house on the weekends, giving her injections of antibiotics, checking her labs because her white count was up and I wanted to make sure she wasn't septic. Her C-reactive protein skyrocketed, so that's an inflammatory marker. Normal is less than 3. Hers jumped into the 160s, which is really high. And that's when I started to get a little suspicious, thinking, could this be that we found this incidentally and that this could be related to cancer? Because it's a nondescript marker, but infection can jack it up. So can cancer, especially at those high levels. Sometimes you have other things that you never quite figure out what they are that drive that up. But I started to get a little uneasy because I thought, well, her primary tumor was on the right side. She's got weird stuff going on with her liver, which is on the right side. Had this severe cellulitis on the right side of her upper body. and she had these wackadoodle CRP numbers. So I monitored the CRP. It did come back to normal, but I was just a little uneasy. And it was actually my husband who said, Krista, you know what this is. Just you've got to follow through with this. So we retook that Galleri cancer screening that I've spoken about before. Now, if you don't remember the Galleri screening, I think it's fantastic. The website is www.galleri.com, and that's Galleri. What is super cool about Galleri, it's a blood test and it screens for the DNA of multiple cancers. I think there are 50. So if you look at what cancers we have screenings for outside of this test, yes, you have your colon cancer screenings that you can do with Cologuard or colonoscopy. You have your mammograms. You have your prostate specific antigen or PSA. That's a bit of a screening for prostate cancer. You have your pap smears, but there are really, if you look at the number of body parts that can develop cancer versus the number of tests that we have early screening for, it's not great. And 70% of cancers aren't one of those that we have screening for. Now, as a note of reference, I had done this on her 1 year post-cancer treatment. So I had a baseline of a negative test after cancer treatment. I knew that if it was positive, it wasn't just a residual marker, that it was actually the active disease, which is what it shoots to screen for. We did the blood test and it came back as positive. So that is not, it's a screening. So screenings are not guaranteed diagnostic, but they detected a cancer signal, the DNA of cancer. And what it can do too is it can identify for you where that's likely coming from. So it will say positive screen, cancer signal detected, and in her case, predicted site of origin. So where this is coming from, it looks like this is breast cancer. Well, that aligned with her history. Obviously, a mammogram wasn't going to show anything because she had had her breasts removed. So at that point, she called her oncologist and asked for an appointment and to get some sort of imaging done. I did not realize until this time that she had not had any imaging as part of her follow-up with oncology in the preceding 5 years. Depending on the type of cancer, they can use different things. You'll hear about PET scans, which are very good with breast cancer. A lot of times they'll use MRIs for follow-up, like a chest, abdomen MRI. She hadn't had any of that, and she really shouldn't have known to be worried about that because she was seeing an oncologist who, in my opinion, this was some negligence. And when I looked at her most recent office note, not only had she not had imaging, the blood work that they had done was a CBC. And so the brilliant note we got from this skilled specialist was that her chest wall exam was normal, meaning they touched her chest and didn't feel any lumps, and that they did a CBC, which looks at your white blood cells and red blood cells, and that was normal. That's not a highly skilled exam, and I don't think that's adequate for somebody who's had metastatic breast cancer. Anyway, she called. She asked them to order some imaging. They wouldn't do it because they questioned the test that was run, and they also questioned who I was and what were my qualifications and my training and who was my collaborating physician. And so basically these kind of ad hominem attacks that delayed her care. And I said, that's fine, I'll just order it. Interestingly enough, Medicare, we didn't even have to have a prior auth because she has traditional Medicare, not an Advantage plan. So another plug for traditional Medicare, there are only a handful of procedures that have to be prior auth with traditional Medicare, and they're all cosmetic. So when we called down to get it scheduled, they said, oh, a PET scan, what's the diagnosis code, what's her history? No prior auth needed. We were able to get her in for a PET scan that week, and the results came back that there were innumerable metastatic lesions on her spine and in her ribs and into her sacrum. So innumerable meaning can't count them. Metastatic meaning this cancer has spread and it's in the ribs that have hurt, that she told her oncologist about. It's her spine and all the way down to her sacrum. So that brings up a couple of important points that I think we have to be aware of as advocates, as patients, as providers. First of all, as a patient, you need to trust your instinct. If she would have just gone with the first time around, well, I've had a normal mammogram, I'm not going to worry about this, she would have progressed another several months before it was located. If she wouldn't have advocated for herself and saying, no, I'm getting a bilateral mastectomy, that's what I want, they would have taken out one cancerous breast, but not the other one. And if she wouldn't have advocated and said, no, this is abnormal, what do I need to do to get screening done now? Then we would have not found this out till much, much, much later. I think the big punch in the gut for her and for me and for a lot of our family isn't so much the cancer, but the fact that she had done all the right things. She had been going to her oncologist regularly. She had done everything that was asked of her, and she got inadequate follow-up. There weren't even, in the labs that had been done, they weren't even looking at cancer markers. So there are blood tests that are markers for certain cancers. And I know that everybody has slightly different follow-up protocols, but again, she has Medicare, which pays for these labs and pays for these tests. And why on God's green earth, before you cut somebody loose for another year, wouldn't you want all of those things to be in order? So one of those cancer markers, the normal level is less than 38.6, 0 to 38.6. Her level when I ordered it was 783. So had her oncologist been doing even just labs without imaging, they would have known something was askew. You can watch those trends and those patterns. And it was really discouraging to me as a provider because I have a fair number of patients, particularly my Amish patients, who go to Mexico for cancer treatment. And I have some concerns about that because it's a different country. And so getting follow-up across international borders is a little difficult. And I've seen some adverse outcomes because there's not someone locally with eyes and ears on this person, and they are putting all their trust into someone that's a country away. But what kind of was a punch in the gut was recognizing, I have people who are coming back from Mexico for cancer treatment who are at least getting routine cancer markers drawn and imaging done to assess to make sure that the cancer hasn't returned. And here we are in America with the best medical system ever and having insurance, and those things were missed, and this could have been found much earlier. That being said, she was able to get in right away with a good provider. She really is great about advocating for herself. We actually got an appointment with the Mayo Clinic. We got an appointment with the James at Ohio State. She had a great experience at the James, didn't end up following through with the other one. They have a really nice program for people over 65 where it's more holistic care, where you meet with not only oncology, but like pharmacy, nutrition, physical therapy. My only concern is why isn't that available for everyone, not just people over 65? It seems like that's the way to go, but they spent a lot of time with her. There are better treatments available now, injections that she can have that can arrest the progress of the cancer, at least temporarily. As far as predicted outcome, nobody really knows, but we do know for 2 to 5 years, the lesions could fail to progress with this treatment. So that's what we're hoping for. Thankfully, her energy's pretty decent. She doesn't have a lot of pain. She just has had some migratory rib pain. Surprise, surprise. Pain if she sits too long on the sacrum, but she's doing really, really well, all things considered. But I wanted to talk about a couple of different principles with that. First of all, it's the whole idea of prevention. So there are 3 levels of prevention. One thing I've been a little disappointed at the more I've delved into my education, is how little it's talked about. When I did my first bachelor's, which was in community health education at Brigham Young University, so this wasn't a clinical degree, but it was health promotion. We talked a lot about prevention and levels of prevention. So you have primary, secondary, and tertiary prevention. Primary prevention is preventing the disease from happening in the first place. So, super simplistic example, but one of the best ways to prevent lung cancer is to not smoke. One of the best ways to prevent cirrhosis is to not be an alcoholic. I mean, so there's some really straightforward things, but it's basically anything you do to prevent a disease from occurring in the first place. That, again, plug for my DNA testing, is a great tool to figure out what are you vulnerable to and how can you prevent it. When you're looking at cancer risks, you're looking at impaired detoxification. Those are things that can affect cancer risk. A lot of different things that have broad benefits, because cancer, it's driven by toxins, infections. It doesn't just randomly happening. The fire is fed, environmental exposures, that sort of thing. Secondary prevention is early detection. So that's what this Galleri cancer screen does, and that's what your mammograms and colonoscopies and PSAs and pap smears do. They're a form of secondary prevention. They're not preventing the disease from happening, but they're helping you to catch it as early as possible. The beauty of Galleri, and I know there are other companies coming out with DNA-based testing, and it's kind of what Cologuard is. I'll back up. So Cologuard is a stool test that is DNA screening for colon cancer specifically. So it's that principle, because every cancer has its own DNA, but by doing it through blood work, they can cast the net much wider, and they can catch things stage 1 that are otherwise impossible to detect stage 1. Tell me, outside of this screening or like sheer dumb luck of some other procedure that accidentally found it, are you going to find stage 1 pancreatic cancer or stage 1 esophageal cancer? There's so many cancers that by the time we diagnose them, they have very, very poor outcomes, because they're not usually diagnosed until someone's very symptomatic, which means that the cancer is usually stage 3 or 4 at that time. So to me, the idea that we can catch things early, that is golden. At this point, it's not on insurance. They've been trying for years. I happen to be a bit of a cynic and think that there are some perverse financial incentives that would drive some people to keep this off of a list of covered exams, because there are a lot of people who make a lot of money off of illness. I think that's disgusting, but that's a whole other episode. Tertiary prevention is prevention of complications, and that's what I want to spend a little more time on. So tertiary prevention is saying, okay, it's too late to prevent the cancer from happening. It's already been detected, but what can we do to keep this experience as holistic as possible? How can we prevent side effects from treatment? How can we prevent pain, fatigue, nausea, some of these other things that can be thrown in? And there is actually a lot that we can do. The challenge I have with our medical system, most places, and this is why so many of my patients go to Mexico, is that our current system is focused on killing the cancer, but not on taking care of the host, which is the person who has the cancer. It's focused on surgery, chemotherapy, radiation, those sorts of things, because we do want to eradicate the cancer, but there are a lot of casualties in those treatments, and the person's immune system, their nutritional status, there's just so many things that can suffer, and we actually have some super cool stuff that can help to mitigate some of that risk. Now, one thing that is just low-hanging fruit is glutathione. Glutathione's produced by your liver. It's your body's master antioxidant. You can boost your body's glutathione production by taking N-acetylcysteine, by taking sulforaphane-containing supplements, by taking Immunical. You can also take glutathione, or you can get glutathione via an IV. It has a lot of published evidence. If you just search, go to PubMed or Google Scholar, glutathione and cancer outcomes or immunology, any of those sorts of things, you'll find some really, really cool data. So by enhancing our body's ability to detoxify, you're going to enhance outcomes. Now, again, everybody needs to have adequate glutathione levels, because this can come into play with our earlier levels of prevention. So I think it's a great thing for everyone to address. But once treatment starts, I'll always remember I had a patient who came to us. She had cancer. She wanted nutrient testing. So we wrote the orders, but even before she did that, I said, I just want you to start on N-acetylcysteine and Immunical, which is this purified bonded whey cysteine that's a glutathione precursor. And in a week, she went to her next follow-up appointment with oncology, and her CBC had normalized. Her white counts were back where they should be. And they said, oh, this is amazing. What did you do? And she told them, and they said, oh, that's great. That's what you should do. Again, why am I the one who's telling her to do this? If that's what she should do, and everybody knows this, why isn't it happening routinely? But that's a whole side note. The micronutrient testing, we've got the same answers for so many problems, but making sure that your nutrient status is adequate. Obviously, diet is key, but if there are deficiencies that can really affect inflammation, that can affect detoxification, we want to help boost that. What you really want is somebody who is going to be willing to work with all of your providers. So we have, newsflash, a new nurse practitioner coming to our practice very soon, Rachel Hill, who has a lot of experience working in oncology and can be a great asset to our patients who have had cancer or who are going through cancer treatment. And I remember having a conversation with her about what percentage of oncologists are open to their patients doing these sort of adjunctive therapies, because you want to make sure that nothing you're doing is interfering with the treatment. We want to be partners in healing. We're not trying to overstep or minimize the need for good treatment. And her estimation, just based on who she's worked with, is that it's about 50-50. There are some people who are open and are happy to work with you and other things you want to do, but there's a good section of them who are a little more old school, who just, no, you only take what I say you can take, the end. If I had cancer, I would be looking long and hard for an oncologist who was willing to look at the whole picture and let me do other things. And instead of just casting this blanket and saying, oh, nutrients, oh, alternative things, they're not tested, they're not safe, they're not good. That's just so ignorant, lack of curiosity. Yes, there are some things that you shouldn't have. Like, because my mom's cancer is hormone receptor positive, they provided a list of supplements that should be avoided because they can have estrogenic effects on the body. So those supplements are things that are actually great for people who suffer from low estrogen, things like resveratrol or rubestrin or even alpha lipoic acid. They can have these estrogenic effects. But that's really important for an oncologist to say these specific things should be avoided. But then they also give you the list of, and really supplements in general don't take them. And I'm like, yada, 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 yada. You're just covering your rear end. That's not intellectually curious. It's not intelligent. It's not holistic. It's not looking at the whole person. And we need to work with everybody's preferences. So nutrients to me are absolutely key. And then finding someone who's willing to, even if they don't order those things, if they'll give their blessing to work with someone like our clinic or Rachel or people all over to say, hey, let's communicate. This person's looking for some natural ways to help boost their immune system, help their energy, aid detoxification, reduce inflammation. Let's be partners and all part of the same team. Some other things that have super cool benefits for cancer, but again, for everything, because really our body, what helps inflammation helps inflammation. What helps the immune system helps the immune system. So it can apply to lots and lots of different areas. As far as detoxing goes, sweat therapy or the saunas are great. I love my sauna. I use it every single morning. I have the Relax far infrared sauna that you zip yourself up in, your little head sticks out. There's a book by Bill Akpinar. I don't really know how you say his name. I'm sorry, Dr. Bill. But it's called No Sweat. So N-O sweat, no sweat, K-N-O-W, sweat. I would say it's not the most well-written book, but he makes some really, really good points. So one thing that he tells that I think is really fascinating, he quotes a book by Dr. Paavo Ariola called Worldwide Secrets for Staying Young. It says he tells the story of the Pontine swamps near Rome, Italy. The swamps were a breeding ground for malaria-carrying mosquitoes. When the swamps were dried out, the local population managed to eradicate the mosquitoes. Hooray! Mosquitoes, gross, malaria, gross. While the malaria problem was solved, the next few generations saw an exponential rise in cancerous diseases. The fever from the malaria had killed off the cancers. So I think that's really an interesting clue. Now, the key isn't to go get a bunch of mosquitoes and get malaria. It's what can we learn from this process? And that gives us some clues about what heat and sweat therapy can do. Sweat therapy via sauna or other methods like raises your oxygen levels in your body dramatically, which is good. Dr. Dewhurst, which is Dewhirst, who was the professor of radiation oncology and director of the Duke Hyperthermia program at Duke University Medical Center, stated that direct killing of cancer cells begins to occur when cancerous tissue reaches about 104 to 105.8 degrees Fahrenheit. So that sort of hyperthermia has to be medically supervised. Somebody is sedated and you are at a medical center that does that. But again, it shows real benefits. So cancer is definitely it's a byproduct of a lot of different things, the accumulation of toxins. Also, emotions, lifestyle, lots of other things can contribute to it, but sauna therapy is something that most people can use very, very safely. Dr. Bill also states here that by itself, and he's quoting here a medical journal, but he says by itself, heat therapy can kill some cancer cells, but its main advantage, advocates say, is making cancer cells more vulnerable to radiation and chemo. So in the Journal of Clinical Oncology, Duke University Medical Center found that 68.2% of their patients who did radiation plus heat had their tumors disappear entirely. So people who had radiation, which was standard treatment, plus the heat therapy, 68% of them eradication of tumor. The people who got radiation alone, it was 23.5% of them. So that is more than double the amount of people who saw eradication of their tumors. So we are not looking to upend traditional medicine and the advances that it's brought, but there's so much that we can do to augment it. Anything that you can do to help your body detoxify, sweat therapy, exercise, having regular bowel movements, breathing clean air, drinking plenty of water, also ionized foot baths, which I've become a big fan of recently. Those are all things that can help your body take out the trash. Anything you can do to optimize nutrient status, because remember, your nutrients are all the workers in the factory making the ATP, that cellular energy, helping the Krebs cycle, helping your body detoxify and methylate. You've got to have that well-stocked pantry. Everybody's got to show up to work. So anything you can do to optimize those, but you will do best if you have qualified people helping you and if you use good tests to determine what your body needs. And then look around for providers who are going to be your partners. Look around if you or a loved one has cancer. I would ask the hard questions of the oncologist. If the person told me, I'm the doctor, you just do what I say, I'd say, not anymore. I'm going to go find someone else. Find someone who's gonna listen to you. It's your body, it's your lived experience, somebody who's going to give you honest information about the treatment, the outcomes, the risks, all of those sorts of things, and is going to be willing to be a partner and to be intellectually curious and look into things. If you have questions about things you want to try, they're not just going to carte blanche say, no, no, it's not what I prescribed. It's not good. That's ignorant and lazy. And I know they're crazy busy. We all are, but you're the one living with this, and you've got to be your own advocate. Be like my mom, speak up. Don't be afraid to ask hard questions. If you have a lot of family history, or if you're at the age when you really should start looking for regularly for cancer, I'm a huge advocate of the Galleri screening. Like I said, not on insurance yet. Their cash price is $950. They'll also let you do 12 months, same as cash. Is it a lot? Yes, but is it really? And if you look at peace of mind, what it would cost you to get cancer and a late stage cancer, and the lost productivity, health, the stress, all of those sorts of things. I've mentioned before, we started doing it for my husband last year. I'm going to add me on now. He has his dad and both of his dad's parents who passed away in their early 60s from cancers, different cancers. And I told him, I said, Eric, they didn't get this at 63 and then die. This is something that was developing, and you may not have had the same exposures or the exact same risk, but you have those genes. Let's work on detoxing, but let's just assume you're at risk. We're going to catch things early, and we're not just going to sit and hope. I've heard him and his brother say forever, oh, yeah, I'm going to die when I'm 63. I'm going to die when I'm 63, just planning on it. I mean, that's great, I guess, that you've accepted your fate, but is it really your fate? See if there's anything you can do to minimize risk, but also to catch things early and to not be a victim of the system, to remember that you're in the driver's seat when it comes to your health, and to always have hope because you were made to be whole. Have a podcast question or suggestion? Text or call us on the podcast info line at 330-439-0686. Thank you for spending time with me today. If you like what you hear, please subscribe to be notified when new episodes release. And remember, you were made to be whole.